Thank you.
I
All
think we
right.
lost someone.
Okay.
That's okay.
Yeah, welcome everyone. Yes, this is our first Wednesdays at noon for January, and we are in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people, and to recognize the land that we're in and how we're all gathered here today. Mi'kma'ki people have been here for over 11,000 years, and to also recognize African Nova Scotian people who have contributed also to this land here too. So I am thrilled to introduce our three presenters today, and you get the full session today. Very excited. We have Dr. Meaghan Sim, Gabby Fera, and Shauna Best. So I'm just going to turn it over to you. And do you have PowerPoint to share?
We do.
Okay.
Yeah.
So we'll let you
Perfect.
take control and share your PowerPoint, and we will let you lead.
Great. Thanks, Meaghan. I think Gabby's going to be the presenter. And I'll just get you. Let me know if you're having any troubles with sharing your screen. Oh, perfect. Okay, it's there. Excellent. So I'll just, I guess, preface this. So myself and Gabby and Shauna and Kaylee as well are here. Shauna and Kaylee are just going to be participating in answering questions if the folks on the call have any questions that are outstanding at the end. We mean this to be super informal, but I just want to turn it over. I'm an implementation scientist at the IWK, and I was brought into the organization with this project as one of my key areas of focus. But I do want to turn it over to Gabby, Shauna, and Kaylee just to quickly introduce yourselves as well and your role in the project.
Yeah, I can introduce myself. My name is Gabriella Fera, and I'm a fourth-year undergraduate health promotion student studying at Dalhousie University right now. And I've been with the Strengthening Transitions in Care Lab since around my second year of university. So it's been great to help out with their projects related to implementation science and health systems. And I was brought on to help with this project this past summer. So doing a little bit of preliminary data analysis that we'll get into today, and then just helping out with data collection and analysis till now. So yeah, that's about me. So I'll pass it over to Shauna or Kaylee.
Hi, my name is Shauna Best, and I am a casual employee now of the IWK. Nursing is my background, and I was a longtime clinical manager in the Children's Health Program until my retirement in 2023. And I've come back to work on some projects, one of which being the evaluation of the implementation of OPOR, which is near and dear to my heart to see how something so huge as a transformation rolls out across the IWK. So yeah, I bring, I think, a clinical lens to the project team to kind of help out with understanding what the context of this kind of project at IWK means. So, and I'll pass it over to Kaylee.
Hi. Well, I didn't expect to speak during this, more so just to observe. But I'm Kaylee Lang. I'm the research coordinator on this project. I joined the project this summer when I was hired onto the Strengthening Transition and Care Lab. I defended my thesis in April, so I come from an epidemiology background, and I'll be handling most of the quantitative data for this project. That's me.
Great, thank you. So Gabby, Kaylee, and Shauna and I represent a broader research team, advisory team that's supporting this project. I also want to indicate that the project is led by or supported by IWK Health leadership. So it is an internal to the organization initiative. And what we'll do today is I will go through what this study is about. And then Gabby, she was involved with the project with her involvement with the STIC Lab this past summer, so summer 2025. And she's just going to go through some of the findings of her work that she was able to pull together as part of this project. And then we'll just talk a little bit about where we are in terms of the project progression and answer any questions that anyone in the who's listening in is interested in. So yeah. We'll give some background in terms of digital technology. So certainly in the modern healthcare system, we are starting to realize the benefits of digital technology in terms of, supporting efficient, safe, and quality care to patients. And CISs are a type of digital technology. There's many that are in the healthcare system, but they can facilitate efficient and quality care by enabling documentation, storage, communication of patient data, instead of having to rely on paper-based management approaches, which can also present their own challenges in terms of data sharing, data integration, timeliness, et cetera. So there's likely to be benefits for implementing a CIS in a system, so that these could be increased efficiency and documentation and communication. But implementation also comes with some challenges as well, and some that have been noted in the literature around increased provider burnout, increased time spent on data entry and figuring out a system when compared to providing direct patient care. So what does this mean, and why are we doing this project? So we know globally, even though so many different systems are implementing or have implemented digital technology, such as clinical information systems, we know that this evidence that describes the integration within a health system context is actually lacking. And as we see more systems around the world adopting, implementing CISs, as well as even optimizing those CISs, it becomes increasingly important to document and study what makes implementation a success or failure, as well as the impacts that implementation will have on the health workforce and the organization as a whole. So that's really what the purpose of this project is. To give some context to our current state, so it remains its current state, even though our go live at IWK occurred about 7 weeks ago. So in current state, it was estimated, this information comes from the OPOR team themselves, that there were over 80 plus health information systems in use across Nova Scotia. There was a reliance on primarily based documentation and communication, but also a hybrid systems also were in the system as well. So both paper and digital operating at the same time. And you can make some presumptions about the challenges that this would have. So the one person, one record, which is known as OPOR, Clinical Information System, is going to be implemented across the province and is in the midst of that implementation. And it's the single largest digital transformation project in the province's history. IWK Health went live December 6th, 2025. So again, it's about 7 weeks, 7 weeks in operation right now. The initial stage of go live was this hyperphase, or known as hyperphase, but we're still in a state of implementation, immediate implementation right now at the IWK. And again, this project presented an opportunity to contribute to the evidence of large-scale digital health transformation within health system and delivery, health service and delivery systems around the world, not only in Nova Scotia, but elsewhere as well. So next slide, please. In terms of a future state, again, this comes from OPOR itself, so you can find this information on the OPOR website. But the implementation of the OPOR Clinical Information System in Nova Scotia is intended to achieve a few different things. So number one, it's intended to move away from paper, manual, and fax-based processes towards a fully digitized and automated workflow. Instead of navigating multiple systems, clinicians will now have access, or the intention will that they will have access to province-wide clinical information through a single unified electronic platform to improve efficiencies and continuity of care. And some of those benefits were previously noted. All hospital-based acute and ambulatory care will be documented digitally in this future state. And then finally, OPOR SIS, or OPOR, is intended to support the standardization of clinical workflows across the province to create a more consistent and coordinated approach to care delivery. So a lot of different outcomes to be realized and outputs to be realized. In terms of our research question, so what IWK leadership is ultimately interested in, and what our team is ultimately tasked with trying to achieve, is to understand how has implementation occurred at IWK Health with respect to OPOR implementation, and what are its impacts. And in order to do this, we are focusing on a few sub-questions. So the first sub-question is understanding the implementation supports or the interventions and the strategies that were used to support this implementation, and then also understanding how they impact implementation or affect implementation. The second question is around how will implementation of the OPOR clinical information system impact IWK Health at an organizational level over time? How will implementation impact clinical workflows? And how does implementation impact patient flow and experience in the system? Next slide. In terms of how we're approaching this study, and the study started in the summer, I guess, once we received RED approval, and we initially focused on Kaylee's work, or Gabby's work, sorry, that she'll be speaking about in a moment. But in terms of the study methods, it is a mixed methods project, and we're using multiple methods to try to address our 4 sub-research questions. And we're using a number of different implementation science frameworks as well, to inform not only data collection, but analysis interpretation. And we're using a mix of primary and secondary data. And when I mean primary data, I'm talking about data that we have to go out and capture because it doesn't exist in the system. And the secondary data is data that's already collected in the system as part of routine reporting structures. And we're using some of that data and working with our partners within IWK to look at that data to understand signals in the system of how implementation is happening. We're also interested, while we're interested in understanding how it impacts IWK as a whole, we've honed in on 13 study environments across all 3 of IWK Health's clinical program areas, which would include children's health, women's and newborn health, as well as mental health and addictions. And these were built around a typical patient journey through each of the different clinical program areas and trying to touch some high points within the system. In terms of the primary data collection, this will occur over a 3-year time frame. So anything that we have to collect ourselves, mostly interviews, has started in 2025 and will continue on until 2028. The secondary data will be accessed both retrospectively, so we're going back 2 years before go live, so that would be December 2023, and we're going prospectively forward, so we're looking at data into up to December of 2028, to give us a good sense of trends in terms of the administrative data and how things are happening in the system. So this little timeline gives a little overview of our different time points. You can see 2025 is our time 1 pre-go live. And then we had the go live happen in December 6th, and it did go live on that day. That was the day that was announced, and it did go live. We're into this time 2 post go live, which I'll speak to in terms of study progression. And then 1 year out is our time point 3 and time point 4. But the administrative data is going to cover, I guess, a 6-year time period from 2023 to the end of 2025, or a 5-year time period. Next slide. So just briefly, and I know the folks in this audience understand what implementation science is, but really we're trying to understand this evaluation using an implementation science approach. And the reason that it's so important is it's the ability to apply theory and scientific rigor to study the bridge between what we know and what we do. It's useful in understanding how interventions such as programs, policies, or practices are adopted within organizations, specifically healthcare organizations. It's used quite frequently, and the factors that impact on this, which can all give us good information to try to evaluate. So in terms of the implementation science frameworks that we're using, and because of the complexity of the project, and you'll start to see the complexity once we get into what Gabby's going to present, but we're using several different frameworks as an approach to design, of course, analysis, and interpretation of findings. So in terms of evaluation, we're focusing on the Proctor Implementation Outcomes Framework, which looks at things like acceptability, adoption, appropriateness, costs, when we're not so much focused on costs at this point, but feasibility, fidelity, penetration, and sustainability, some of those outcomes. The CFR would be quite familiar to, I'm sure, many on this call. So the Consolidated Framework for Implementation Research, which is really a determinant framework that aims to understand implementation in context and factors that impact implementation. Then we have the theoretical domains framework, which is focusing on things such as behavioral theories, and helps explain why health providers or healthcare providers do what they do, or others in the system, why are they doing what they're doing. Then we have the ERIC, which is a consensus-based framework outlining the important interventions that support implementation. So high importance and high feasibility are things that we want to see in a system, and Gabby will speak to that as part of her work. And then the ICON, which is the implementation in context framework, which is a meta framework that situates implementation within context and will help interpret the implementation from the points of view of various actors and domains within the system. Next slide, please. So in terms of our data collection analysis, this table helps to kind of address what we're going to be doing and what we have started doing in terms of data collection. So for sub question 1, what are the implementation and supports and how do they affect implementation? We're using things like document analysis. We're using interviews with the implementation team and care teams as well, and end of shift reports to understand, and that would end of shift reports during the immediate go live period to understand what the supports were, as well as how did they impact implementation, and then the implementation science frameworks that we've assigned to those specific approaches and how we're approaching this. In terms of understanding how the implementation of the OPOR clinical information system impacts the organization over time, we're doing repeated interviews with IWK staff and physicians. We've employed a change fatigue scale, which is a very short survey that understands change fatigue, or it's a validated survey that looks at change fatigue within an organization, not specific to OPOR, but just change as it's happening and how it impacts on the workforce. We're actually looking at the change readiness survey, which was employed by the OPOR team leads, as well as any human resource and occupational health reports. So things like attrition, hiring, movement into different parts of the organization as well. In terms of understanding implementation on workflow, we are using medication administration observations as a proxy for clinical workflow. And that baseline information has already been captured, and then we'll be repeating that through time point 2 through 4. And then we're also looking at SIMS data, so the Safety Incident Management System. And we're looking at that data within that's already captured as part of IWK routine processes to understand some impacts of the CIS on clinical workflow. And then in terms of the patient flow and experience, again, we go back to those 13 care environments, and we're mocking up patient journeys using some de-identified and aggregated data from the secondary data sources within the organization. Again, that's going to be 2 years pre-go live so that we can trend that data before the go live occurred, and then 2 years post. So, and that's going to form the bulk of Kaylee's work as well. So a lot of data, a lot of organization, and a lot of socializing this work within the organization, which is really important.
Yeah, so I think it's now onto my part of this presentation. So I'm just going to be going over some of the data analysis that we did during T1. So this was prior to go live, and it was specifically during summer 2025. So just as a note, things did start to change very quickly after we did this analysis in the summer, specifically in the months and even weeks right before go live in December. And so a lot of new strategies have been added since we did this. So the list included in this presentation won't be completely up to date, but we will be revisiting it soon, just to add in the new strategies along with a timeline, making a note of when new strategies came in and why they came in. So to address what gaps exactly is what we'll be looking for in the future. So that being said, just to give a summary of what was done during the summer, we first mapped out all of the implementation strategies OPOR and IWK were utilizing for this digital transformation. And we did this primarily through document analysis, meaning we looked at all the information available through the OPOR hub, town halls, and roadshows that were done to understand what was out there to support the implementation of the CIS. And we use the expert recommendations for implementing change implementation science framework that Meaghan discussed a little bit, otherwise known as the ERIC framework, to code these OPOR and IWK strategies. And to give a very brief description of what ERIC is for those unfamiliar with the framework, it essentially encompasses a set of defined and expert agreed upon strategies that can support or improve the implementation of new practices in healthcare settings. And we use this to code the OPOR IWK strategies to one or more of these ERIC strategies to see how the OPOR implementation strategies align with what experts recommend. And then finally, we looked at how important and feasible the ERIC strategies are rated by the experts to help determine whether OPOR was utilizing strategies that are considered most impactful and realistic. And to be super clear, this exercise of coding that we did was not an assessment of how effective the OPOR strategies were. It was more just looking at how aligned OPOR implementation is with what experts recommend. And then that effectiveness piece will be informed later by the data collection and analysis we're doing now. So just to make the small clarification that I'm really only going to be talking about the first part of this question. So what are the CIS implementation supports? So to break down this process of how we looked at all of these implementation strategies, we used a mind map type of method to organize the different strategies, putting them into our own categories first. And I know this mind map on the slide won't be super visible for you all to see, but it should just give you an idea of how many strategies we found and the complexity of what we were finding. So we categorized all of these strategies in terms of what the OPOR or IWK strategy was attempting to address. And just to name a few of those categories, we had a people category, which included implementation strategies involving the creation of, for example, different working groups. We had an education category, which involved the online learning and classroom training sessions. And we also had an information and artifacts category, which involved sources of information for OPOR. So that could include the OPOR Hub, which was essentially what housed all of the OPOR related information for staff, and also events like the Roadshow, where OPOR did essentially a pop-up visit with demos and information sessions for IWK staff. And after that, we mapped all of these OPOR IWK strategies. After we did that mapping process, we then coded them all to the ERIC framework, and we verified our coding during our team meetings by talking it all through together and ensuring we agreed on how the strategies aligned with the various ERIC strategies outlined in the framework. And again, it's difficult to see the names of everything on the slide, but essentially what we did was organize the ERIC strategies by the 9 clusters identified by the authors. And these are represented by the different colors that you can see along the x-axis. And then we have the OPOR IWK implementation strategies along the y-axis. And then all of the green boxes that you see just indicate an OPOR IWK strategy being coded to one of the ERIC strategies. And this visual helped us to see the clusters of the ERIC strategies that were most utilized by OPOR and IWK. And from what we found out of all the clusters, the develop stakeholder interrelationship and the train and educate stakeholder clusters were the ones that were coded for most often. And I'll just do a little zoom in on this. So as you can see here along the x-axis, the darker green color represents that develop stakeholder interrelationship ERIC cluster, which we had many OPOR IWK strategies coded to, because a lot of the time we were finding that OPOR strategies involved attempting to facilitate knowledge transfer and communication between end users, champions, and leadership groups, with some examples being the Executive Leadership Council and also the various kinds of champions that were used as strategies. And we also saw a lot of the implementation strategies being coded to the train and educate stakeholder cluster, which is that blue one down there. And the OPOR education and learning team did develop many different kinds of educational resources like online and hands-on end user training, which would be the types of strategies that we had coded to the ERIC strategies within that blue cluster. And after we organized our coding, we also looked at how experts have ranked the ERIC strategies in terms of their importance and feasibility. And we utilized this to further our analysis because it helped us gain a clearer picture of where OPOR implementation is well aligned with what experts deem most important and feasible. And in terms of this diagram, in the first quadrant, which is that green one, we have the ERIC strategies with high feasibility and high importance. And then in the third quadrant, which is the gray, we have the ERIC strategies with low feasibility and low importance. And the green dots are representing the ERIC strategies that we have OPOR or IWK strategies coded to. And then the red dots are representing ERIC strategies, no OPOR strategy or IWK strategy were coded to. And in doing this, we could flag some potential gaps of the implementation approach by noting some of the highly important and highly feasible ERIC strategies that weren't being utilized by OPOR. So, for example, if we zoom in on quadrant 1 here, which has the strategies rated as highly important and highly feasible, there are quite a number of red dots here. So a lot of OPOR strategies weren't coded to a number of ERIC strategies that are considered to be highly important and feasible. So one example of this would be dot 46, which represents the obtain and use patient and family feedback. So that's an ERIC strategy that we had no OPOR or IWK strategy coded to. So nothing really aligned with this. So it highlighted a potential gap here in engaging with patients and families during OPOR implementation. But as you can see, some were utilized. So for example, one of the green dots, dot 4 on the far top left, was assess for readiness and identify barriers and facilitators. So this was coded for and is also an ERIC strategy deemed highly feasible and important. And an example of what we coded to this ERIC strategy was the OPOR change readiness surveys that Meaghan discussed briefly, but they essentially allowed staff to convey their feelings and readiness regarding OPOR implementation, and in theory could help identify barriers and facilitators to implementation. But again, just because this OPOR strategy got coded to an important and feasible ERIC strategy, it doesn't necessarily determine its overall effectiveness in this specific context. And that's something that we're going to need to uncover by analyzing the qualitative data from the interviews, as well as the quantitative data we're collecting, which will bring me to the next slide, which I believe is Meaghan talking about our current progress and what's next.
Great, that's awesome. And again, just to reiterate what Kaylee, sorry, I keep calling you Kaylee, and Kaylee and Gabby. Gabby is presenting is the work that she did in the summer, and it should be noted that we have to revisit this because of the immense transformation and the rapid transformation that was taking place within the organization between probably September and the go live. And so again, there's a number of strategies that need to be remapped and reconsidered, but we're going to add a timeline to those as well, so that we can see a timeline of progression in terms of those strategies. So more to come in this space. In terms of some additional progress, so that was an immense amount of work. So thanks, Gabby, for all your efforts this summer on that. It was a really good learning experience for her to go through this and to facilitate us through those types of consensus meetings around this. But the other things that have kept us quite busy is we've done these pre-go live interviews, so these time one interviews. So they started late August up until go live. Our last interview was actually held, I think, less than 24 hours before the go live occurred. At 7 a.m. on December 6th. And we interviewed 78 IWK physicians and staff, as well as OPOR leads, with the overwhelming amount of interview participants being physicians and staff, about their perspectives on implementation to date, the strategies, again, that they felt worked well, and those that landed flat for them, some foreseen challenges or impacts that they were foreseeing, and just to get a good understanding of how implementation had gone to date. Of those participants from the IWK, we asked them to also complete the change fatigue survey, which I mentioned. We had 69 completed surveys, so we had really high uptake. I think 69 of 75 people so completed, which was great. And then at the elbow support report. So at the elbow is a strategy that was employed by IWK in the hyperphase, which is the immediate go live period. And they're folks that were situated on various units and in service areas to support staff in navigating the system. And that was their sole role. We recruited 5 of those at the elbow participants across our care areas, and they completed 49 surveys. So we basically asked them in those surveys what they helped the staff with, what were the biggest challenges, and were they able to address their challenges through the work that they did with them. So we have those surveys as well completed. In terms of the quantitative data, we've got quite a bit to go through. So decision support is going to provide things such as wait times and a variety of other metrics that are already captured routinely in the system. I referred earlier to the safety incidents within IWK, and this will include diagnostic imaging. So we will be looking at counts for those across the various SIMS categories. I don't believe we'll be looking at the narrative of those, but we will just see where categorically we'll understand where were the safety incidents noted. And again, the importance of looking at this retrospectively as well to say, is it's just, is this a blip or are things, are the trends routine throughout the system and throughout go live? So that's what we'll be looking for. So it's important to look back 2 years as well as go forward 2 years as well. In terms of lab turnaround times is one of the things that we're looking at. The Medical Advisory Committee Council has provided some physician HR data for us to understand FTE equivalents and movement in the system. Environmental services, so this is really like room or bed turnaround times that we're looking for. Previously, this was documented in a paper base, so we're looking at one of the units of interest and we're looking to see how that's evolved in the new digital space. And then we're also going to look at some human resource and occupational health, safety, and wellness data. So a lot of data to come. Oops. In terms of continued progress, so we submitted a manuscript to BMC Health Services Research, which is under review right now, and it's on our protocol. So basically what we've presented to you today. In terms of, and this is a good segue from Gabby's presentation, but where we noted that there was a gap in that ERIC, high importance, high feasibility, around patient and family engagement within the OPOR implementation. We actually submitted a project grant, developed and submitted a project grant with some partners within IWK, and that was submitted in October. So we're hoping that that's successful, but it's really focused on understanding patient and family impact during digital transformation and helping to bridge the evidence in that space. In terms of our interview data, we just finished cleaning that from time 1. And so we are in the midst of doing that analysis right now. And so hopefully we'll be able to come back to this group and present some really interesting findings once we have had the chance to organize those. And again, we'll be using CFR and TDF to really understand some of those factors within the organization, as well as some of the potentially behavioral domains that are impacting or that have impacted on readiness for implementation as well as implementation. And we are going to be starting our time 2 interviews with IWK physicians and staff beginning next week. We've had tremendous reuptake. So we've reached out to all of the participants from time period 1 to see if they're interested in participating. And we've heard from almost 60% that yes, they want to speak to us again. And that's been wonderful. And so we are starting those interviews next week. And again, that analysis will just happen at once we're able to complete those. We feel it'll take about 6 weeks to speak to the folks within IWK. And then we also have an additional list of folks to reach out to who were instrumental within the immediate hyperphase of OPOR Go Live, and that weren't part of our original time 1 interviews. And we should say that I should note that the interviews are not dependent on one another. So if a staff member wants to speak to us in a year, we would welcome that. just because if you didn't participate in time 1 or time 2, that has no bearing on whether you can participate going forward. So each of the time points are independent of one another, I guess is the best way of putting that. So yeah, so that's where we are with the project. It's a big project, and with a great team that I should also speak to. So I'm leading this with Shauna, and one of the great things about this project, and one of the things I also wanted to note, is that Shauna really, I think that co-leadership model, that's research, implementation science, as well as folks that are within the system and have a history within the system, and understand to have that institutional knowledge, is really critical to this project working. And so thank you again, Shauna, for all of your leadership there. Dr. Janet Curran, who I understand leads the implementation science area of focus for this center, is also involved in this project, as well as Dr. Andrea Patey, who's an implementation science expert as well, and works within the quality team within IWK. Leanne LaRock, who is IWK leadership. Katie Hollis, who is a director of pharmacy, but has also had a leading role within OPOR implementation, particularly in the last few months leading up to go live. Dr. Jill Chorney from mental health, clinician scientist there. Dr. Shannon McPhee from the Children's Health Program, as well as Gabby and Kaylee, who are both on the line today. So huge project team, and advisory group, and lots of interest. So any questions?
Yes, open it up for, thank you so much. Brilliant project. Massive.
Massive. Yeah.
I'll just, I'll wait and see if anyone from the audience has a question. And Margot, go.
Hi, Margot.
Uh-oh. Oh, there she is. I think we lost her. Oh, no. I'm sure she'll come back on. Well, we're waiting for Margot to come back on. Oh, no. Yeah, there she is. Okay, we lost you. Now you're back. Go ahead, Margot. We can't hear you.
Maybe if you want to type it in even.
That's a good idea. Yep, Margot is typing. All right, we will wait.
I'll sign
She's
back
going to
in.
sign back in. Okay.
Okay,
Is there
great.
anyone in the meantime who has a question? I'd like to jump right in. While we're waiting, I will ask a question. Yeah, just thinking about, you had said there's 13 different places in the IWK where you are, interviewing people from. So I'm just thinking about the diversity that is there. So from, the NICU to emergency to, maybe not so fast-paced places, but I don't know if you can comment on what's coming forward, but is there a real diversity of experience, or are there some common things coming out? Yes. What are you looking for there?
Yeah, so that's a great question. We didn't come prepared to present in terms of the
No.
analysis for the qualitative, because we do have to go through that process and be systematic and rigorous there before we bring those findings forward.
But maybe what are you
at a high
anticipating?
level,
Yeah.
at a high level, and I'll let Shauna also jump in as well, and Gabby and Kaylee, who were part of those interviews as well. At a high level, we are seeing some consistency in terms of experience. And we're also seeing some diversity depending on where you work, which is going to be great. So we will, to extend that a little bit, we will be taking that into consideration. I don't think we'll be able to do it at the level of the provider in terms of, are you a nurse? Are you a doctor? Although there are some things that have come out for considerations around that, but I won't get into that. But we won't be able to subdivide in terms of, all physicians said this, that kind of analysis. But certainly at the program level, I think that we'll be able to speak to some diversity, and potentially also to at the whether you're in a corporate kind of services sort of structure, like something that supports the entire organization, like pharmacy, lab, DI, dietary. There are certainly environmental services. There are certainly things to be said around that. But I'll also toss that question over to Shauna and others if you guys want to comment on that too.
Yes, I think we were trying to be really purposeful because Meaghan, I think we anticipated that we were going to run into this with, even though IWK is smaller than perhaps going to some other larger centers. As you point out, the diversity is real and it can be quite different. And so we were very purposeful in sending out the invitations to kind of target that, to know that we were getting good representation across all 3 clinical programs and the support services, as Meaghan highlighted, but also that we were trying to get a broad look at roles, because we know there's been quite a turnover of staff, in comparison. So we wanted to look at not only being on campus at IWK, but also being in the community or being in like offsite, being in small teams of just 1, 2, or 3, being in large teams of 50 and 60. So we really tried to do cross sections in anticipation of trying to capture the diversity.
Yeah, and
there's so much thought. Mm-hmm.
We found too, Meaghan, just to add to what Shauna was saying, even in our next go around with the time 2 interviews, we've had good representation, and then we've tried to ensure that we have good representation moving forward, that all the programs are represented and different levels of roles as well within the organization. Because we realize that we can't do as many interviews the next time so we're going to be going to about half or a little less than half of those interviews. But we also want to keep it wide open enough so that when we repeat this in a year, we have people who want to speak to us again. So they have a little bit of a longitudinal lens to what they're bringing. So yeah.
Mm-hmm. Yeah,
if that
very
makes sense.
exciting. Yeah, no, because I'm sure you can anticipate, what may or may not be going. So you've developed your questions in a particular way, but then, yeah, some other things might emerge that are surprising. So yeah, this is awesome. Thank you. I'm not sure if Margot's back or not.
Maybe she's having some.
Oh, there's Margot. Go ahead.
Oh,
Hi.
hi.
Sorry about
Hi,
that.
Margot.
Well done. Wow, what a massive project, but a really impressive team and work so far. So just really want to compliment you on your work and the scope of the analysis and the thoughtfulness of it is incredible. I'm curious, are there other hospitals that are comparable to the IWK in Canada that have done this?
Yeah, no, that's a great question. There are other hospitals that have implemented. Yes.
Mm-hmm.
That's one response. The second response is, are there other hospitals, or the second part is, are there other hospitals that have published and done the research
Mm-hmm.
around this? So there is a hospital, so Trillium Health Partners in Ontario has done a similar project. And we had the opportunity to connect with them in the summer after we had put in our REB, and we were starting to, plan for the initial time point 1 data collection. And slightly different, but very similar in terms of some of the approaches. So they did do some qualitative, it was mixed methods. They did qualitative work. They looked in some other care areas. They looked in heme onc as an area of focus.
Mm-hmm.
And they were clear on that around the sort of the continuity of care piece and seeing, people going back into their communities and how that all worked. So there are some slight differences in terms of the projects, but we left it open to the ability to maybe have some kind of cross work happening in the future, because they have published in this space, and the project's quite similar. There's some similarities, and they were really excited about our work. Different system, but again, we're not evaluating the system, although we recognize that the system is part of it is the intervention that we're looking at as the central focus. So So they were using Epic, and our system is Oracle Cerner. So yeah. So yeah.
I was also wondering, and it's good to have another team nationally that you can reach out to and commiserate with, or get some collaboration with. I was wondering about the ERIC. Who is considered expert in the recommendations? Are they local experts? Like, are they people from the IWK who would be experts from their profession or field, or these evidence, like research published experts?
Yeah, they're research published experts. So the implementation strategies. So I think oh great. Thank you. Thank you, Lisa. Thanks for attending. They are experts within the implementation science field.
Okay.
So it's a consensus body that came together. So for example, I think it's Dan Schroeder, who's one of the leads for CFR, and is a name that would be familiar with many in the implementation science world. So they were on that panel. So it was a consensus group of implementation science experts that came together to identify. And it was really around trying to determine and define the strategies, because the strategies are named differently. So it's coming to consensus around what that strategy is and a concept of what that strategy is. And that was the intention of that consensus group to come together. And then they did their own work around the plotting that Gabby showed and relayed the implementation strategies. So again, we don't know, even though these are deemed to be important, feasible, or lower importance, lower feasibility, et cetera, and you could see the spread, we still don't have an idea of whether or not, even if it was important and feasible, did it work? Was it impactful? Did it have a positive impact on the implementation, or did it have a negative impact? So what we will be doing with all that work that Gabby was able to pull together, which is actually incredible, because it's a lot of strategies, a lot of strategies within the OPOR space. It's a lot of strategies within the ERIC space to kind of get your head around. And so just to show the complexity, I think the visuals were really about showing the complexity of that. But what we will be doing is layering that with the additional data to really understand, okay, well, education and training was used really heavily in this implementation. What did people think about it? If those were the two big strategies, the stakeholder relationships and the training and education that people heavily leaned on, then how did they land within this implementation? They're known to be important and feasible, but how did it work? So that's the next layer that we'll be bringing to the strategy piece. So, but we really needed to do that work to really have a good understanding about what was happening and to try to ground it and organize it. I guess it's the organization of that. Yeah, that was really our goal this summer, to do that.
Really interesting. I'm looking forward to, your next round of information sharing.
Yeah, absolutely.
So
absolutely.
Thanks for coming today.
Yeah, absolutely. Thank you. I should also mention too, although we will have some academic, outputs from this. The intention is also that this informs the ongoing work. Implementation isn't just, December 6th and in the immediate hyper phase, it's ongoing. So this is meant to inform, the leadership at IWK, and this was their vision of doing this project and having this project in-house, and also supporting, Nova Scotia Health is starting to go live in May. So we hope that some of the information that we have been able to capture to date will help to inform that implementation as well. So yeah, to be continued, I guess, in terms of how that goes and where that goes. But yeah.
I know Lisa's posted something in the chat. Lisa, did you want to follow up with your question or comment? I'm not sure if Lisa's.
Oh, yes. Yes. Okay. Given that Trillium has also done a large OPOR-like project, would there be sufficient similarities in data collection methods for future analysis when you get further into this project? Yeah, I think so. That was sort of how we left the conversation. We met with them in July, and at that point, we were still, storming and forming and planning. But I think that we could do a go back around and see if there's some comparisons that we could do. And one of the things they also mentioned that they didn't have any patient facing information. They used the providers as a proxy for patients in terms of, I guess that's the best way of putting it. So when they did their interviews, they asked providers what their perceptions of impacts to patients were within that space. So we're hoping, if we're successful with the project grant, that we're able to get that, first voice understanding of how this has impacted people receiving care within the organization. So, yeah.
And the implementation science frameworks and theories that you are using, I've certainly seen many of our students using them, so I've become a little bit familiar with them. But if those are being used, I know, globally or across Canada, then I guess that would bring out some really interesting and comparable data too.
Yeah, absolutely. I think the Trillium folks use CIFAR in their analysis. Yeah.
Yeah.
So, which is a good one to use because it gives you that contextual piece. So yeah, we're going to be layering on the TDF and some of the others, of course, for interpretation. So yeah, a lot of work.
Absolutely. Oh, thank you for doing this. Anybody else in the audience have further questions or comments? I don't hear anybody. I don't see any hands going up. Okay, anything else, Meaghan and your team, that you'd like to say before we close up?
I don't know. I'll turn it over to others. Shauna, Gabby, Kaylee, you guys good?
Yeah, all good. Thank you.
Great. Thanks for the opportunity.
Yeah,
And
no, thank you so much.
I feel that there's going to be some interest in the qualitative findings, so I'm looking forward to coming back and part 2, part 3.
No. We would absolutely love to host you again. And yeah, this is just really cutting edge research that we're really thrilled to be able to hear about. So thank you so much. Great.
Yeah, thank you for the opportunity. And yeah, reach out if you have any questions or want to, get involved. There's, I don't want to speak on behalf of Janet and Christine Cassidy, who co-lead the STIC lab, but there's always lots of students around. So
yeah, great.
Yeah,
learning and mentoring opportunities. Wonderful.
That's right.
Well, thank you so much. And
Great.
thank you to our audience who was able to participate. And of course, this is being recorded, so I'm sure other people will be interested to watch it afterwards.
Thank you.
Great.
Thank you for
Okay, well,
having
take
us.
care.